Everyone over. Great, and it looks like we are recording, so we'll just wait a moment for folks to come in from the waiting room, and then Julie, I'll give you the thumbs up when we're ready to get started.
Hey, Janie, can you tell me the correct way to pronounce your last name?
Yes. Hi, Julie. It's Gullickson.
Gullickson. Okay, I guessed right.
Yes.
I wanted to make sure I didn't mess it up.
Nope. Thank you. I appreciate it. It's been, yeah, sounded out a million different ways, but thanks.
Thank you.
Yeah.
Okay, I think we are close to critical mass. So Julie, I think you are good to kick us off.
Terrific, terrific. Well, thank you everyone for joining us this afternoon. First, I'd like to share a disclosure that this meeting is being live streamed and recorded. For those of you that don't know me by now, my name is Julie Ibrahim, and I'm a co-chair for this council. I am chairing today because the First Lady is out of town traveling with the governor, and I have a message from her for you all, and it's as follows. I'm sorry I cannot be with you today. I am accompanying Governor Kotek on a trade mission to South Korea and Japan. I know this council will have an important conversation today about how we can better support peers in the workforce, and I look forward to watching the recorded presentations later. Thank you for your continued dedication to this work. So today, this is the fourth series of meetings highlighting the professional types that this council is focused on, which are those that the HEC Talent Assessment identified as having projected shortage and/or high risk of turnover. Today's meeting will focus on peers. Thank you to everyone who helped make this meeting possible, lending your voice and your expertise. During the presentations, please hold your questions until the end when we will have a brief dedicated discussion time. First, Amy Baker, the Governor's Behavioral Health Initiative Director, will provide an overview of peers in the workforce. Following that, we will move into presentations on successful strategies. First, we'll hear from Janie Gullickson, Executive Director of the Peer Company and member of this council. Afterwards, Kimberly Lindsay, Executive Director of Community Counseling Solutions, will present. Then we'll have a 15-minute break, after which Dwight Holton, Chief Executive Officer of Lines for Life, will be speaking about their Youth Line program. And then finally, Tammy Paul, Executive Director of Oregon Family Support Network and member of this council, will present as well. To wrap up our time together, we're going to have time for a group discussion to talk through what we've learned today and how it applies to the work of the council. So, do we have Amy here? Okay, good. All right, we're going to begin with Amy Baker, the Governor's Behavioral Health Initiative Director, who will set the foundational understanding of who these behavioral health professionals are, how they practice, and their general career pathways. Amy?
Thanks, Julie. Alex, are you going to hook me up? Excellent. So today we're talking about peers, and largely we're going to, in my part of the presentation, focus on the different pathways and credentialing types. Next slide, please. It is hard to underscore the value of peers in the behavioral health system and across the spectrum. I've watched this workforce grow and bloom over the last 20 years, and it has fundamentally changed the way that we do our work, the way that we are able to engage clients and sort of renewed our ability to really be client-centered. And so you'll hear that quite a bit more from the folks who are presenting, but I would be remiss if I didn't point out how important this workforce is. Next slide, please. So there are two different credentialing pathways that exist in Oregon right now, and one of them is the traditional health workers. And traditional health worker is this umbrella term that's used to describe the different area of peers and the specific work that they do. And you can see we have the birth doulas, community health workers, personal health navigators, and peer support specialists and peer wellness specialists. For the purpose of this presentation, I'm largely going to focus on the peer support specialists and the peer wellness specialists. They have probably the highest number of workforce in the behavioral health realm. So within that, for both, it includes family support specialists, youth support specialists, mental health, adult, and adult addictions. Next slide, please. And there are 4 categories, which I just described. And these have some of the criteria that more specifically lines that out. For youth, I believe they can be as young as 14, but not older than 30. And what they all have in common is really folks who have lived experience, which brings a unique lens and a unique ability to relate with and to people who are struggling. Next slide, please. Hopefully you can see that. So this talks about the difference between peer support specialists and peer wellness specialists. There's a lot of similarity, but there's some differences too. Peer support specialists typically work in the behavioral health field and are really focused on individuals with behavioral health conditions, whereas peer wellness specialists are typically more likely to be kind of cross over into the physical health realm. They may be part of a medical home. They may be focused on wellness activities and are sort of integrated into a integrated primary care and behavioral health service. For the peer support specialists, it's a 40-hour OHA approved training program, whereas peer wellness specialists, it's 80 hours. The scope of the peer wellness specialist may be a little bit broader in terms of their ability to assess needs. And then obviously both are required to be certified and also to have supervision. Next slide, please. I am going to cover this briefly because Janie is going to talk about it more extensively, but the peer scope of practice is, it's pretty broad. It's, I think, an important part of the conversation when we talk about peers around ensuring that we're supporting them in a role that they're really equipped to do. I think one area that we see peers work a lot in the field is really around kind of using their personal experience to engage folks into care and then support them through that care. They often can help with things like care coordination and basic needs support, coaching, assisting families around how to work in an IEP meeting, maybe accompanying someone to an AA meeting, and then advocacy and cultural mediation in terms of making a bridge between individuals who may be have their own unique attributes and how to make that work within a broader context. Next slide, please. The certification of peer specialists, I covered some of that already, but just to a little bit more in depth, that it requires the oral health training, background check and fingerprints, peer wellness and peer support specialists also have to get an MPI number for billing. And then there's a slight difference in the requirement for CEUs every 3 years for recertification. Next slide, please. In addition to the traditional health workers, we also have certified recovery mentors, and that certification process goes through MACBO. And to be a CRM, it requires a 40-hour addiction training program, also the oral health training, the background check, and then 2 years of recovery as of January 1st, 2025, which was a change from prior, where it was 1 year, and it looks like it's gone back to 2 years as of January 1st. And then for the CRM2, CRM2 really builds upon CRM1. And so it's an additional 40 hours of advanced training in addition to the original training, an exam, and 500 supervised internship hours in peer domains. And those may be used for to get somebody certified as a CADC1. Again, the 2 years in recovery and signed code of conduct. Next slide, please. And so for context, just so that we know how many folks we're talking about, and I'm pretty sure there's no chance anybody can read that slide, so I'll just like highlight it for you. So the peer support specialists in adult addictions in Oregon, that's about 2,058 peers who are certified. For the adult mental health, it's 1,784. For family support specialists, it's 299, and peer support specialists for youth are 434. And the peer wellness specialists in the addictions is 492. Peer wellness specialists is 394, and peer wellness specialists on the mental health side is 700. And the other piece that I want to add to this to make sure that I cover, like when we talk about peers, is really around how peers are such a great pipeline into the workforce. I know there's a broader workforce, whether that's becoming CADCs or QMHAs and eventually QMHPs. Like we honor the work that peers do as peers, and sometimes we have peers who want to learn more and advance in their studies, and so they go on to additional areas of the workforce. Next slide, please. And then lastly, these are MACBO numbers. There are a total of 3,941 certified recovery mentors in the state. And you can see that the vast majority of our peers have a high school degree or GED. And the other piece that I would add is that our peers tend to are more likely to reflect the communities that we serve in terms of race and ethnicity. Next slide, please. And that's all I have. If there are clarifying questions, I can take those now.
Yeah, we have about 1 minute for questions, so 1 or 2. One question. Okay, you'll always have an opportunity at the end to ask questions. So thank you, Amy. Now we're going to have 3 presentations on successful strategies. We're going to start with Janie Gullickson, Executive Director of the Peer Company. Janie is a person in long-term recovery from addiction, serious mental health issues, homelessness, and incarceration. She began her work as a peer support specialist in 2011 and has served as executive director of the Mental Health and Addictions Association of Oregon since 2017. That is now rebranded as the Peer Company. Janie holds a bachelor's degree in social and behavioral health sciences from Linfield College and a master of public administration and health administration from Portland State University. Welcome, Janie.
Thank you, Julie. And thank you, Amy, for that great foundational level setting nuts and bolts of peer support services and certification in Oregon. Thanks for reading the introduction. That's going to save a little time. I have probably more slides than should ever be allowed for a 15-minute time slot, but I hope that it is a resource to you. And so I will be going through them fairly quickly. And I have them ready if share screen is needed, or I can happy to just
I think Alex is
whatever.
gonna share screen here
I
in a
was-
second.
Awesome.
Yeah, Janie, I can share
Yeah.
them if you'd like. You have access to share the screen if you would prefer, how Chad usually does it. So if you want to go ahead and share and present, go for it. Otherwise, I'm back up. Let me know.
Okay, thank you. Let me see really quickly. Here we go. You'll see that. I'll move into presentation mode. Will it let me once I share? Yes. Okay.
Can see it. It looks great.
Fabulous. Thank you. And sound check, am I okay? Sometimes my microphone just decides to take a break without asking. So
Yeah. Can hear you loud
All
and
right.
clear.
Thank you. All right, introduction's been made. We can move through this one pretty quickly. Peer support is a profession, and we've got a growing, robust workforce, as was just shared with us. Again, I am the executive director of the Peer Company, formerly MHAAO, and we are so excited to rebrand to a name that, well, folks can remember and say, and hopefully the folks that are looking, seeking peer services can find us. Just thrilled for the support and enthusiasm for that change. We are a peer-run organization. I think there's probably a general understanding of what that means, but around 90% of our 150 staff at this current time identify openly as having that personal lived experience of mental health and or addiction challenges, as well as 51% of our board. And we have a lot of direct service programs. That is the bulk of our organization, with over 45 unique programs across the Portland metro region primarily. But today I want to focus on this slide on our training projects, internship projects, continuing education. And so one of our great peer certification trainings is Peer Wellness Specialist Training, and that's under our optic department, the Oregon Peer Training and Innovation Center. And that Peer Wellness Specialist Training is one we focused on. The head's connected to the body. It's part of recovery. When we look at supporting that whole person, and whether mental health, addiction, both, all the intersecting life experiences, physical health is such a critical piece of that. And we have many programs inside of medical spaces, whether hospitals, emergency departments, primary care, and I believe even a CCBHC. And we also have our e-learning hub for continuing education, and there's a wide variety of accessible, great, I think they're great, continuing ed self-paced modules available on our website. We have the peer pain training for peer support to get that extra education on how to support people living with chronic pain. And then we have Project Peer, which is a HRSA-funded program that incorporates peer training as well as, I believe, 100 internship hours with community partners who have collaborated with us on that, as well as a stipend that they get while they are doing those internship hours. And then Peer Apocalypse, our crown jewel, that's our gala event for the peer workforce, allies, and other organizations that employ peers, and a lot of education, CEUs, networking, and really that support for the workforce itself. Getting to come together for those 4 days in Seaside once a year has been so meaningful to so many. And we just had our 12th year, very, very well attended, and hopefully serves the community well. Why peer support? As Amy shared when we were talking about preparing the presentation, you're preaching to the choir, so I don't need to take the deep dive on this, but we're all here because there's a behavioral health workforce shortage, and how are we going to help support expansion of that longevity in the various careers? And peer support has been an untapped, willing, and available workforce. We're cost effective. I don't like to say cheap, but we're cost effective. Lots of bang for your buck there. And then that path to employment where many of us have barriers to employment, and we just want to give back. We want to work. We're enthusiastic, grateful for our recovery, and excited to support others. And peer support is pretty old, and especially this first one in recorded history in a medical setting back in the 1700s in France. I can't pronounce the hospital. We've got Dr. Pinel, many of you may be familiar with, but we also have Jean-Baptiste Poussine, who was a patient at that hospital, and Dr. Pinel hired him. He's quoted as saying, there were great reasons for hiring someone with lived experience. They were kinder, they understood, and more humane. And I've done this presentation on this slide for 10 years now, so I've just jazzed it up with some little cartoon bubbles. Peer support is a profession, and because we stand on the shoulders of giants, there is that civil rights-like movement, the Mad Pride movement, even, having beginnings here in Portland, Oregon. But it's not something that just popped up 10 years ago with certification. There are core values that this work is founded on, and it is really driven by the person we're supporting. Peer support is a trauma-informed principle. Peer support is always voluntary, and sometimes, especially in criminal and court settings, the judges or attorneys want to mandate peer services. Like, these are so great, they're so effective, look at the outcomes. And we respectfully share that we are that one service that is in the system, not of the system. And we want to reduce that power dynamic as much as possible. So please, it is a core value, core principle of the work that people voluntarily engage with peer support. There's enough mandated services out there. And then peer supports, there is the core competencies, the scope of practice, SAMHSA, the National Association of Peer Supporters. There are lots of places where people with lived experience doing the work have come together and documented, and almost to a fidelity, created the core competencies for the profession, and then therefore informing the scope of practice as well. And so these core competencies, the scope of practice, the practice standards, then all come together to form the job description. And then in Oregon, we have those certifications that Amy talked about. And that also informs the scope of practice and the statute behind the profession. There's some considerations though that or challenges. You know, they they can be one and the same. And we show up with our past front and center. We wear our lived experience of our worst day, our worst years, on our forehead and in our job description and job title. And when we model recovery and we can, you know, meet folks right where they are and have that shared lived experience, something magical happens. And a lot of times when peer support is implemented, there's only support from leadership who understands maybe why peer support is being added to the team. Maybe there's not a supervisor available that fully understands or has been trained or has even been a peer support specialist themselves. And sometimes funding constraints, peer support is just a one person in a very clinical, medical, or court setting. And then what we found too is you want someone who's ready to work and work in the environment and setting for which they're being hired. Just having lived experience is not enough. While it's a critical component, it's just one piece of that whole role. And then peer drift, which is out of scope work. Now, peer support is 10 plus or 10 years or less in Oregon as a certified profession. And so a lot of organizations, while meaning well, haven't really been trained on how to incorporate peer specialists. And I know for myself, when I started as a peer specialist, weren't sure, you know, what to do with me at first, had me read the psychiatrist notes to mimic those in my note taking. And so, you know, I was writing clinical, what I thought were the right thing, but they were more clinical and I was writing notes in ways I shouldn't have. So there's lots of ways that peer drift happens. And we've seen that more and more with the explosion of the workforce and really the support for hiring and incorporating peer services. And that's where supervision is critical as well. There are peer support roles and there are peer informed roles. And there's that Venn diagram where there's crossover. Sure, even in billing for peer services, there's the case management code. But that's not the role that we are playing. And I use the analogy of case managers give a person a fish, peer support specialists teach a person to fish. They go fishing with them and empower them to learn how to find their own fish. And then there's navigators, and all can be informed by that lived experience and even be out about their lived experience. But it is vital that we understand the scope and the role of peer support versus these other roles. And it's a career path, as we've seen as well for those entering the field. I added this OARs for supervision. You know, it's not always possible to have someone supervise peer support specialists who have been a peer support. I think it's more common now that the field has, you know, and the profession has grown the way it has. And if you're in an organization that bills Medicaid, there's those requirements for peer supervision and then clinical supervision. And, oh, Taylor?
Just a friendly time check.
Oh, thank you. Okay, we are almost to the end. Oh, we are at the end. And there were a couple of things that I wanted to touch on, and one is that clean time requirement, that recovery time requirement. And Amy, thanks for touching on that. It's I think there's not enough time to go into it as an employer of the challenges that can come up with that, but would love to maybe discuss that offline or at a different time. And all these links lead to the actual documents. So if you want to take the deep dive, there it is. Ta-da. Thanks.
Thank you, Janie.
Yeah.
Again, if you have questions, jot them down. There'll be time at the end to ask. All right. Now we're going to hear from Kimberly Lindsay, Executive Director of Community Counseling Solutions. She holds a BS in Psychology from the University of Oregon and an MS in Psychology from Walden University, and has worked in the behavioral health field since 1991. Under her leadership, Community Counseling Solutions has launched innovative programs, including the Equine Program at Lakeview Heights, the David Romphrey Oregon Warm Line, and Juniper Ridge Acute Care Center, while providing outpatient behavioral health services across 5 Eastern Oregon counties. Thank you, Kimberly. Take it away.
Kimberly, you are muted.
Also, Rachel, did you have a question real quick?
Sorry, I thought I lowered my hand when I heard you say questions could be at the end, so I will
Oh,
wait.
Okay, all right,
Apologies.
thank you. Go ahead, Kimberly.
It's hard to follow in Janie's footsteps. She touched upon so many important things. And Janie, I hope that we can meet someday. I love that picture that you put up. So great. And thanks, Amy, for the invite. I don't know that I'll take all 15 minutes. So you might have some extra time here. I was going to give a brief overview of CCS, but Amy or somebody supplied a great overview of CCS. So I won't talk so much about that. I will mention briefly the David Romphrey Oregon Warm Line. That's probably how CCS is best known for. Our peer work. We started that back in 2004. And what I'd love to say about that is that when David and I, first of all, in the spirit of transparency, David and I came up with the peer line at a bar, having a glass of wine, and there's just some brilliant work that happened with David in that way. And we started it in Wheeler County. So I think it's important to note that when we talk about serving our underserved areas, our rural areas, and diversity, equity, inclusion, big things can happen in small places, in small spaces. We started it was 5 hours a week. It was Friday afternoon from 3 in the afternoon until 8. And the first week we had one phone call, and it was David calling the peer support worker asking how it was going. So we do have one log call. Today, in the most recent quarterly report that we put together, we have over 21,000 calls a quarter. So I think that's fabulous. I always give a shout out to Ebony and OHA for their continued support of the Warm Line. It's now 24/7 and bilingual, so it's doing great things. I would, that's where CCS employed its first peer, was back in 2004, and I feel like we were kind of late to the game at the time. David taught me so much about the importance of peer work, and today I'm glad to say that it's a part of every single CCS outpatient and residential program. Over 25% of our workforce at CCS are peer support workers in some fashion. And there's I don't know how we ever did this work without them, candidly. So there's a quote by, I think his last name is Lecoq, and he said, "No one can whistle a symphony. It takes a whole orchestra to play it." So the work that peers do at CCS is so incredibly important. I've recently been listening to more classical music, and then I have to ask the why of what makes it beautiful and what's important and the different instruments. And so I'm gonna say something that's maybe completely weird, but the most underutilized and least well-known instrument of a symphony is called the double bass. It's a string instrument. Anybody familiar with the double bass? So maybe just me. I promise you that you will absolutely notice if the double bass is not present at a symphony. It is what brings out those deep chords and great harmony. And for me, that's what I think about when I think about peers at CCS. If they're not present in a conversation, we're rarely moving forward in a clinical discussion. We need their voices. I need their voices. So one of the ways that we think about how do we recruit, support, and retain peers, and how do we keep them separate? Janie talked about peer drift, and that's something that David talked about with us years and years ago. If your organization doesn't have policies and practices that are present at the outset for preventing peer drift, you're doing yourself and the peer a great disservice. And so one of the, like, it's just so simple, but what we say here is when we're talking about how to protect the peer work is don't ask peers to do non-peer work. Don't ask them to take a client to the grocery store. Like, anybody could do that. I could do that. I want the peers to be sharing their lived life experience. So we start with looking at how it is that we are doing our recruiting. Recruiting is very different. Very few peers go to professional job boards to look for peer work. They don't go there. You got to have the people on the street doing the recruiting and putting the information out there in that space. On the interview process, always, 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 we have a peer on those interview panels every single time. It's so critical and important. And of course, the value of the lived experience that they bring. One of the things that we just didn't realize we were doing is, and we've had to do some changes, is around looking at our internal stigma. What is our conversation like? Like when we say this person is only 2.5 years in recovery and we're talking about a client and we're concerned about some choices that they're making, and we have a peer sitting at the table that has 24 months in recovery, how did we just invalidate them and the important work that they're doing as an employee for CCS? So we do a lot of training with our staff on how we address stigma, both externally as well as internally. I want to also mention the importance of the supervision. And again, Janie talked about that. When we first started to do this work, we had clinical people supervising peers, and it was a disaster. It was so invalidating for our peers. For the last 15 years, we either have peer supervisors supervising peers, or we have a support model where we have administrative people supervising the peers for administrative things and peer supervisors supervising clinically. um, how do we maintain the purity? I have this role that I use around here called clinified. And that's Kimberly's version on taking a peer and making them a clinician, or giving them that pathway and letting that be, or making that the only path for them to advance. And that's what I want to circle back to here in a couple minutes is maybe some ways to address that at the local and state level. The worst thing that we can do is clinify a peer. We if a peer wants to become a CADC and go on and get their bachelor's degree and their master's degree, because that's what they want to do, that's great. But when you kind of force them into that, because that's the only career pathway for advancement or for some kind of financial increase in their salary, then I really feel like that's a shame on us. I do not want to lose those most excellent peers to the clinical work. Some of the challenges I think that peers face are around the criminal history background checks. So I think we've all experienced this. We know some amazing people who cannot find work due to their criminal history. And I want to share a personal story right now. I've been there was a high school classmate of mine, really cool kid, great. He beat me out. He finished 10th and I was 11th in the class. And so the top 10 got honors and medals. And I like to tell him that he, anyways, I didn't get it because of because of him. He was a really smart kid. And he became drug addicted and went on to serve 10 years in prison. He just got out. Now he's been clean for 10 years, right? He's been clean. And in prison, he was very, very, very active in peer support and was an active part on different treatment teams. Came out with all kinds of recommendations, and he is struggling to find a job. I would love for him to work at CCS. Love it. He would be amazing, but he cannot work at CCS due to his background. So I understand the need to protect individuals, those very vulnerable individuals that we're working with. Absolutely. I don't know what the right answer is here, but we lose a lot of people in Oregon due to the criminal history background check requirements. Wage equity. I'm going to try to not talk too much about this. I mentioned earlier about the pathways for peers to make more money. We lose peers because they don't make as much money as they would like. Everybody wants to advance. So we have to create, I think, pathways in Oregon for greater career advancement. Right now, you can become a peer or a peer supervisor. And that's it. And so at CCS, I've been thinking about peer support 1, peer support 2, peer support 3, putting some additional educational requirements in there, some experience requirements, and increasing the pay. It would be amazing if Oregon took the lead on that, because my experience is I create something and it's not like Kimberly is great, but I might create something like this and then Oregon comes behind and creates it and it's not the same thing that I created. And then I have to go back and adjust things. So I would love it if Oregon could create some more pathways in the same way that we have this natural progression in Oregon where we have the QMHAs and QMHPs and your LCSWs, and with each of those you have different amounts of pay. Something like that for peers would be great, and I think it would help keep our peers in the workforce. Yeah. So there's also there's a national certification for peers. Mental Health Organization or Mental Health of America has a national peer certification, or at least last time I checked, they did. So again, on the CADC side, we have CADC 1, CADC 2, then you have the NCAC 1 and CAC 2. People will often pay higher for those higher levels if that's something that Oregon can do. That's a challenge maybe that I have for Oregon, and how can we incentivize this really important work? Yeah, so I want to just briefly mention Van Gogh. So I talked about classical music. I'm going to talk about painters. Some of you have seen A Starry Night. It's one of his most famous works. And A Starry Night was painted while he was inside a mental health institution. The greatest gifts, some of the greatest gifts that we see in society today are from those that have struggled the most, and to the degree that we can elevate our peers who have that lived life experience and celebrate their successes and keep them painters, painting that beautiful work. I think it's incumbent upon us to do that. So I'm going to stop there because I can talk a lot. Thank you for listening. Thanks, Amy. That's it. I have an interview at 3, so I'm going to have to jump off at about 2:55.
Thank you, Kimberly. I really appreciated your symphony analogy. That was beautiful. Thank you.
Mm.
All right. We have a 15-minute break. You can please, if you can please stay on Zoom, but you can take your camera off, take your microphone off, and be back at 3 o'clock sharp. Thank you. Hi, Dwight. And team.
Hello.
Hey.
Oh.
Oh,
Good thing we
we're
just-
still on break, but you're going to be up next. Okay.
Can you hear us okay, Julie?
Oh, yeah. Yeah,
Great.
perfect.
Terrific.
Yeah, I'm chairing today because the First Lady is traveling.
Yeah, she's in Korea, I think. Yeah, no,
Yeah.
we're thrilled to be here, and I was able to catch the beginning of the meeting, so
Oh, okay, great, fantastic.
Hello, and just a friendly note that since you all just joined, that we are recording, so just know that.
while we're still on break, I did want to make sure we had a video which I think Alex has queued up that we'll go to about 90 seconds and well, maybe 1 or 2 minutes into our presentation.
Hey,
But I
Dwight.
think you guys have queued up, right?
So, the PowerPoint that you sent, the video is not working in the PowerPoint. So I just sent you a message about if you wanted to share that from your side, I'll promote you as co-host so that you can go ahead and share that.
I could do that if it's easier. I can send you a link to it.
If you're able to share it from your end, that would be great. And if you're not, then go ahead and send me that link.
Okay, if you can promote the Dwight as opposed to the conference room
Great.
to co-host, then I'll do that.
You got it. All right, I'll get you set up as co-host. Thank you.
That's a bummer.
It's not controlled that way. Alex, do you happen to know, will I have to make any adjustments to make sure the sound is delivered? Sometimes in the olden days, you used to have to. I can't remember if you do now or not.
I think it should be ready to go, but if there are any issues, we'll hear them right away and we can adjust.
Great.
In worst case scenario, we can always distribute the link and folks can mute themselves, watch it, and then come back.
And Alex, I just sent you the link as backup too.
Great, thank you.
Belt, suspenders, and otherwise. Hey, Rick. Hi, Janie. Summer. I saw everybody last week.
Hey, Dwight, also, I'll ask you to introduce your team members too, real quickly. I'll cue you on that.
Sure, as soon as you're, yeah, we're ready whenever you are.
Okay. All right, everyone, welcome back. Our next speaker is Dwight Holton. He is the Chief Executive Officer of Lines for Life. Lines for Life helps 50,000 families annually through crisis line services, including the Suicide Lifeline, Youth Line, Military Helpline, and more. Before joining Lines for Life, he served as Oregon's U.S. Attorney for 15 years as a federal prosecutor. I didn't know that, Dwight.
Yeah,
Where he
kind of
launched, what?
the Justice Department is a very different place today from what it was when I was there. I was just gonna say.
Learn something new. This is where he launched efforts to improve access to addiction treatment and mental health services, including convening the nation's first statewide prescription drug abuse summit in 2010. So Dwight, take it away and please introduce your team members.
Great. I am really delighted to be here, Julie. Thank you so very much. And it's great to see so many people that I get to work with regularly. We're really impressed with the work of the Behavioral Health Talent Council, and we're delighted to be here. As Julie mentioned, I'm CEO of Lines for Life. Lines for Life is a nonprofit dedicated to preventing substance use and suicide. We do three things really well. We do prevention, we do crisis intervention, and we do policy and advocacy around both suicide and addiction prevention. I'm joined today by Emily Moser, who is the National Director of our Youth Line program, and by Yeti, who is a Youth Line volunteer. I'm gonna let these guys run the show for the most part. I just wanna say that Youth Line is our youth-to-youth crisis intervention helpline, where we train and support young people to help other young people in crisis through calls, texts, and chats. We take young people who have an early interest in mental health and we give them skills, experience, and confidence to do this work. Simply put, our youth volunteers are Oregon's workforce for behavioral health for tomorrow. At any given time, we have 130 to 150 youth volunteers at 5 different places around Oregon who work on the crisis line, on the youth line. They talk to about 25,000 youth every year from all over the nation, mostly in Oregon. The biggest chunk is in Oregon, but it's really from all over. Our most recent addition is a location in collaboration with the Balmer Institute at University of Oregon. We are delighted to be such a central part of the workforce pipeline. And with that, I want to hand it off to Emily and Yeti, who will tell you more about what we do. And I want to make sure you get some quality time with Yeti to get an experience and a sense of the experience from the youth volunteer perspective. Emily?
Thanks, Dwight. We are super happy to be here today. Truly at the heart of our work is the youth adult collaborations that we have with our Youth Line volunteers. So Yeti is here with us and will probably do more talking than either Dwight or myself do. I will fill in the blanks sometimes, and we will welcome questions from you all as we work through this conversation. The first thing I want to do is explain just real quickly that Youth Line really does 3 different things as part of our work. As Dwight mentioned, we are a crisis support and hotline with teenagers helping and young adults helping other teenagers and young adults. In order to do that work well, it's super important that we have relationships with the young people that do this. It's very serious work. It's very important work. So workforce development and youth development is a core component of being able to have a youth line at all. And then lastly, we do engage in the state of Oregon with education and outreach, where we have a team that goes into the classroom and into the community to educate and normalize mental health and what it looks like to be healthy, encourage help-seeking behavior, and normalize what it means to reach out for help when you need it. All of that to say, we have a little video that we want to show you that, again, who we are is about youth. This is a youth-led, youth-driven video that we created for schools, just to give you a little bit more information about what we do.
And of course, it's not working. Hang on a sec. Let me try one more time. It's sharing, but I'm afraid it's coming up blank. Alex, do you want to try?
Here, give me one moment here to put this up. One sec.
I don't know why it's coming up blank.
We're no stranger to technical difficulties, so
Yeah.
at all.
I think it's been normalized, right?
Exactly.
And I'm just putting this out there because it happened to me at an all staff last week. There is a button where it says include audio when you share screen. Again, you may already know it in doing it. Just trying to help a friend when someone helped
We
me.
appreciate it, Rachel. There it is. Yay.
Now I'm gonna go ahead and play it and let me know if you're not hearing it, okay?
Yeah. We are not hearing it. Why do they make this so hard? Under what circumstances would you not want to hear the audio, right?
Yes, that is strange, and I have it set so that the audio should be shared. But we have two options. I can either go ahead and share the link with everyone, and we can take, 2 minutes to watch individually, or read along with the captions. Taylor, do you have a preference there or an idea?
I would kick it to Julie.
Okay.
Julie, what would you like to do?
I think the audio is probably important, so let's get off and
I'm gonna go ahead and share this with everyone. Chat
Let
here.
him watch. Let him watch.
Julie, we can skip the video. It gives a nice sense of what the room is like and things like that, but we'll just convey it.
okay.
We got it.
Okay, let's do that, and then everybody, paste the video into your own files or whatever and watch it later.
And part of what's fun is you hear some more youth voices, but before we hand it over to Yeti, the one thing I'll just say to you that we try to convey to folks is when we tell people that we run a youth crisis line, we get the sense that most people's images goes to black and white and like a sad space where teenagers are depressed and talking to other depressed people, and it's kind of hard, and they all go, oh, it's nothing like that. This is, as you'll see when you see the video, this is much more about it being a youth space around energy, et cetera. And Yeti can speak to that too. Let me turn it over to you.
Yeah, so one of the things that we wanted to cover is why have a youth line at all? So, and what are the benefits of youth helping other youth and this peer-to-peer related service?
Okay, like we all know, adolescence is a huge time of change. Their emotions, their high stakes social situations, and academic stress. That's one of the biggest ones that everyone has gone through. It's this transitional phase that some people just need a little bit of help to go through. And that's what we do. We like being there. We like being present. Youthline is one of the few programs that does just that. They use peer helpers who are aged 15 and up to support their peers who are 24 and under. We help them develop coping strategies, we listen to their problems, we help them devise solutions to their problems, and we kind of help them realize what self-care is and how they can take care of themselves. So why us? Teens fear judgment. I know we've all just tried to hide some things from our trusted adults. I have too. People that are my age, they're just naturally more easy to talk to. And Youthline, we have peers, like I said, 15 and up. So we're there to affirm, to validate their experiences and listen, not to judge. We're also not a direct part of their lives, so we have no opinions over what they can and cannot do. My personal reason for joining Youthline is I want to be in a world that is compassionate and cares about its people. This is my contribution to that goal. Would you like to add something?
So yeah. Thank you. This is why we work together every day. It brings joy. So a couple of things just to kind of add to that from the adult perspective is that we also know that the research shows that teenagers and young adults are more likely to reach out to their peer for support and advice before they reach out to an adult. So part of what we like to do on the lines is some of it is prevention upstream and skill building as it's related to it's okay not to be okay. It's okay to reach out for help. Can we help you identify who your trusted adult is? And can we help you build in some self-care, some skills around that? Some of our callers have never reached out before in their life, and the stress that they're feeling is around things like all the things that Yeti mentioned, but they've never felt any of that before. They're feeling anxiety and they don't even know what it is. So being in a position where we have the relatability of working with young adults, working with each other, it just eases the tension. And we're looking for that first good experience in reaching out for help and then being able to take the next steps forward. So this is a workforce talent council. So thinking about the workforce pipeline and how Youthline fits into that pipeline is the next thing that we want to talk about a little bit. And thinking about the types of experiences that we have on Youthline that help feed that pipeline in a way that is really contributing to what happens next for our young volunteers. I'm going to let Yeti go first again.
So workforces, they need workers who have emotional intelligence, can have resilience, and are able to adapt to situations. Youthline trains us in all three. So when we're talking to callers, we use active listening skills and are able to deeply connect with them and talk about their struggles. Situations can also differ to every caller, and they require different skill sets, which once again, Youthline trains us to have. We're also supposed to be ready at all times in case the conversation takes a sudden shift or something develops. So we're always ready with those skills as well. For the workforce pipeline, it gives us an opportunity to experience and understand the nature of behavioral health and how we want to join that profession, or maybe if it's not for us. So it's kind of like an early opportunity to see if this is something that fits our passion and our understanding and something we'd like to continue in the future. We also already kind of have early exposure to HIPAA guidelines. That's an example of what we do. So what we talk with our callers about, that's confidential, and we're already practicing those skills. We also fill out digital call reports, which kind of also gives us that experience and exposure to systems that are already being used in the behavioral health industry space. Yeah.
I think one of the things that I would love to point out, thank you, is that when we have these conversations and we're talking to other adults around this work, is that oftentimes as we're working together, that the skills are built in such a way that it's organic and it's natural. So you learn how to use an electronic health record because that's part of the work. And it becomes a very natural thing as you move through this process. Talking about HIPAA, we joke all the time about the fact that that our volunteers sometimes can't talk to their parents around a contact and or a caller, and what that means to be able to manage through that without even knowing that HIPAA compliance is something in our world that is super important, right? We all take very seriously. They do too, but it's not like at the forefront of the work that we do on a regular basis. So when we do this work, it's about the training, it's about the skill building, it's about what they learn in particular and very specific to crisis intervention. Yeti talked about things like active listening and validations and as part of this process, which we all know are skills that we try to use on a regular basis in the work that we all do. And in addition to that, there is also this big piece of the use of technology. When we're on shift, the volunteers have 4 different software systems that they use for the different platforms that we use. So there's one for text, one for chat, one for emails, and one for phone contacts. And so this multitasking piece also becomes very natural as as they get trained, they also practice and practice and practice and practice. So with the support, of course, with master's level clinicians and skilled clinicians in the room. Do you all have any questions about that?
I don't think we have time for questions right now. We're going to
Okay.
hear the next presenter, and then if you all can hang on at the very end of the presentations in about 15 minutes, we'll have time for questions.
Okay, that's perfect.
We're happy to do that.
Yeah.
Julie, I would just kind of wrap up that we've seen tremendous growth in Youthline over the last 10 years. When Emily took the helm of Youthline 10 years ago, we had about 9 volunteers and 1,000 contacts. We now have, as I said, at any given time, about 130 to 150 volunteers at 5 different locations, talking to 25,000 people nationally. We've had support from the state. We'd like to grow that, frankly, because we think we're an essential part. It's really interesting. You know, we invest in exporting hops and in exporting wine and exporting other great things from Oregon. This is youth mental health that we're exporting from Oregon. We're really thrilled with it. And we would love to talk about how we can partner and grow it.
It's really impressive. Thank you, Teams Line for Life. And hang on for questions. Everybody, please watch the video when you have time. And next, we are going to hear from Tammy Paul, the Executive Director of the Oregon Family Support Network, who will present on her successful strategies. Oregon Family Support Network is a statewide peer-run organization supporting parents and caregivers raising children with behavioral health or complex health needs. She is a certified traditional health worker with a family support specialist credential. She holds a master's degree in intercultural relations and serves on the Children's System Advisory Council and the Addictions and Mental Health Policy Advisory Council. And she is faculty for the Oregon ECHO program through OHSU. Welcome, Tammy.
Thank you so much. I am going to try to get all the right buttons pushed here to share my screen. And are you all seeing that?
Yes.
Oh, perfect. So let me just here. Okay. Oh, I'm gonna move this too. All right. Well, thanks. And I was reflecting on the statement that was made after Janie's presentation, how hard it was to follow that. And now I just want to say I'm following 3 outstanding presentations. So I hope I have a bit more to offer, but really appreciate my colleagues in this space. So as Julie said, I serve as the Executive Director of Oregon Family Support Network, and I'm going to share a little bit here. Oh, my slides are not working. What is happening? Oh, there we go. Share a little bit about who we are and what we do. So OFSN is, as was mentioned, a peer-run organization. We are statewide. We serve all counties in the state. One of the things that's unique about OFSN is that we are also a family-run organization. And what that means by definition is that a minimum of 51% of our staff and our board must have the shared lived experience of raising a child with mental health, behavioral health, or other complex health needs. I'm very proud to say that 95% of our staff have that lived experience, and 100% of our board members have that lived experience. We're also the Oregon chapter of the Federation of Families, used to be called Federation of Families for Children's Mental Health, but they shortened the name, thankfully, so much easier to say. And our work is really the specialty of family support specialists under the traditional health worker umbrella that Amy talked about earlier. And that is the work that we do. We hold the certification for all family support specialists in the state. So that is our specialty. And so that's what I'll be speaking to today. Little bit about what we do in terms of the workforce. We do support and both in terms of development and sustaining the what we refer to as FSS, Family Support Specialists. Try not to use those acronyms. Workforce through certification and continuing education. We also provide monthly ongoing group coaching as well as individualized coaching around the 43 national competencies for family support specialists. I think we're also the only peer specialty that has, that Oregon has adopted those competencies for implementation in our state. We also provide co-supervision in clinical settings where perhaps a peer supervisor is not available. And so really to help bring that integration of the peer practice. And then finally, just offering some specialized training around the workforce. And I'll talk a little bit more about why that's important to the workforce later. So wanted to touch on some of the what we often think of as unique challenges in both recruiting and retaining family support specialists and peers in general, I think. And one of those is that when you hire us, right, we bring our lived and living experience with us. My experience as a parent of now 3 young adults who, as young people from the age of 4 on, all experience mental health and developmental disabilities. My experience doesn't go away. My kids still, now that they're young adults, still have challenges. And so that is why we refer to as parents our living experience, because our kids will always be our kids. And there are times when that challenges us to balance work and our family obligations. One of the other challenges, or another challenge, is really that our work is in the child and family serving systems. And oftentimes those systems, in terms of navigational support, look very different than the adult serving systems. There's also a different relationship because our work is supporting someone who's receiving services as opposed to the services directly and uniquely applying to us as parents. For many peers, there's impacts of the trauma maybe that we have experienced or that the person we're working alongside experiences, that vicarious stress and system complexity that adds to the challenges that we are navigating both personally and in as part of the workforce. It's interesting that I think 2 of the previous presenters also talked about peer drift or role drift, so I won't go too much into that. But this idea that one of the challenges in retaining our workforce is really oftentimes the underutilization of the role. What I find, and so skipping ahead to lessons learned, but when I talk with our staff, they want to do the work because they want to give back. They want a process for families that may be different from their own. And so if they're underutilized or not utilized in a way that's meaningful, that contributes to workforce turnover. And finally, when I talk with family support specialists, they often say that due to the demands that are needed to support families, the critical thinking skills, the relational skills, the cultural responsiveness, that if those things are not supported through professional development or ongoing support, that also has a significant impact on whether or not they stay in the workforce or they transition out. So then what works? I think, and much of this, I'll share some citations at the end of the presentation. Much of this comes from research as well as the work that we do across the state with the workforce itself. Flexibility in work environment that honors that lived and living experience. As I mentioned, at any point, a family support specialist may get a phone call that their child is in need. Maybe they have been excluded from an environment. There's all kinds of things that can happen at any moment. And so that flexibility in the work environment and understanding that is really critical to retaining the workforce. They also tell us supervisors who understand and value the family support specialist competencies. And so I'll share a little bit later. One of the best practices is really having supervisors that understand the core competencies of the workforce, and that helps the workforce work to their fullest potential. Healing-centered environments and peer-informed teams. We work with a workforce, and I know this is true for a lot of peers, but I'll speak for what I know best, which is family support. We work with a workforce that often comes with significant trauma, personal trauma, system trauma. And so part of what we have to create is an environment that allows people to heal that trauma. We talk often about when we hire someone into this work, we want them to have transcended their experience, right? That's the word that gets used. But it's really this idea that I have metabolized my experience. I have digested my experience so that I can use that to reflect on and offer suggestions or offer feedback or use my lived experience without it re-traumatizing myself or those people around me. So offering those healing environments is really critical for a workforce that comes to us with some pretty a past that has trauma, not just impacting their day-to-day work, but also can be re-triggered in the workplace. The next is really about hiring a workforce that mirrors the communities. And I know that this gets tossed around, but one of the things that we have experienced is when we are able to hire family support specialists who are members of the community, who are at 4-H groups with families, that are at soccer matches, that are in the stores, they have a grounding in the community. And so it's not just mirroring how we look on the outside, but it's how we operate in the community. And that is important not only to the workforce, but it's important to the success of the folks that the workforce is serving. And finally, systems that are responsive to family and community needs. And we hear this usually from family support specialists who maybe are advocating for a family and advocating for a family's needs. And it may be unconventional or not traditional, but it is usually culturally responsive. And so the success of our work is so dependent on systems that can be responsive and nimble to the unique needs of families and specific communities. So what are some innovative practices? And I'm only going to highlight 3. So I'm just going to, it was hard to determine what were the top 3. So I'm not even going to say these are top. I'm just going to say there's 3. One of the things that we think of as an innovative practice is offering multiple workforce access points. In other words, how do we make the workforce accessible before there's a high acuity level? How do we make the workforce available and accessible in community? Providing those family support specialists, and as I mentioned earlier, that are not just in the community, not just mirroring the community, but they understand the community, they understand the essence, they speak the language, they are intimately engaged in the community. And that's that access point, right? When I know if I see someone at my son's soccer game that is working in behavioral health, right, as a family support specialist, I know that I can connect with them there. We have something in common. And then I put in here, one of the things that OFSN does is we operate the parent warm line called Reach Out Oregon. And that is a no barrier access into behavioral health. And this is a place where we find, because it's free to any parent, any caregiver in the state, and it's accessible through a variety of methods, that this is often the entree into understanding or even broaching the subject with a parent that behavioral health or mental health might be a factor or a dynamic, or that there could be some support offered to them. So really looking at this innovative practice as how do we have multiple access points for the workforce? Yes, I'm guessing it says time check. Good, okay. Thanks, Taylor. The next innovative practice I want to talk just briefly about is that OFSN has become in the last year a nationally licensed training site for peer supervision for clinical providers. And this is through the Family Run Executive Director Leadership Association, National Association. And we have been we delivered 3 of these trainings to the clinical supervisors in IIBHT with really good results. And so I think about this as an innovative practice because the foundation has already been established, and now I think we have the opportunity to really expand it. The third is workforce endorsements. And this is an innovative practice because I think it allows the workforce to continue with the core competencies that make the workforce a workforce, and it provides that practice level specialized skill development in environments that are specific to things like child welfare, crisis response, forensics, etc. So what have we learned? We've learned that employing family support specialists through family-run organizations yields better outcomes. We have learned that payment models for peer-delivered services vary in effectiveness. We know through evidence that family support specialists, peers in general, reduce recidivism, increase engagement, and strengthen family-driven care. That we complement, not replace, other behavioral health professionals. Ongoing professional development is essential to sustaining the workforce. And family support specialists are required to have lived experience, but that doesn't preclude them from other credentials. Many of our peers also have bachelor's degrees and master's degrees. I was asked to list a few policy recommendations, so I have these here. We would say embed family support specialists across all levels of the child and family behavioral health continuum. with the idea that early intervention prevents those high acuity needs. Ensure access before system involvement or diagnosis. Create more referral pathways from primary care, pediatrics, and other behavioral health providers, and support holistic payment models as opposed to minute by minute in-person payment models that can really impact the effectiveness of the work. There are some statistics here that I'll just leave in the PowerPoint. Here are the resources for those statistics. And did I make it, Taylor? Okay. All right. Thanks.
Tammy, thank you so much. Thank you. So we have heard some great presentations today. We have about 20 minutes before wrap up. So first of all, if you have any questions that you've held for the end of the presentations, please feel free to ask any of the presenters at this point. And you can just come off mute and shout it out.
I guess I just want to thank the presentations. I thought they were great. This maybe not be a question, but something I'm wrestling with in my mind is Kimberly was talking about the danger of clinification of the peer teams. I'm wondering about the risks and the benefits of purification of the clinical teams. I know our youth support specialists and family support specialists do a family perspectives training for our clinical staff. A lot of them are young. I would say that they, by and large, have their own lived experience with their own mental health, but many of them don't have child raising experience or maybe as much life experience as people who are a little bit older. So anyway, I've just been kind of wrestling with the concept of the fact that like everyone sitting here does have mostly, I would say, I have lived experience with my kids, stuff, maybe different extremes. I've certainly have my own lived mental health and substance abuse experience, and just like we often, though, we're trained clinically to not speak about such things. I mean, my training maybe is just even more old school than what they're teaching today, but we were told no pictures, you don't talk about anything. And I know my daughter's therapist was expressing to her that she'd had her own suicidal ideation growing up and was very open about her experience just off the bat, which I thought was great. So anyway, I'm just like trying to, in my head, not make sense of, but just think about how purification of the clinical teams is beneficial to the system, but also then we don't want to muddy roles or, we want everyone working to the top of their license type thing. Sorry, all of that. That's what I'm thinking about.
Do any of the presenters want to respond to that before I call on Ebony?
Well, I'll just quickly say that when you talk about the purification of the workforce, obviously we're talking about peers in a slightly different context. We're talking about youth as peers. We learn an incredible amount from our youth line volunteers all the time. And, not to put too fine a point on this, but yet he's 15, right? And it has this remarkable sophistication with mental health. And part of what's amazing about our youth line volunteers is that they bring both this remarkable sophistication with mental health while still being knuckleheaded teenagers, right? So they get in, there's a 5-year-long debate over whether Welch's or Mott's are the better fruit chew that we should get for the snack pile, right? So we get kind of both.
So
do you have an opinion, Welch's versus Mott's?
Mott's.
Mott's.
Mott's are better.
Yeah, see, so that was not practiced. I knew that she would have an opinion on this. So but it's also true, Emily kind of kicks me under the table when I say this sometimes, but we use our youth to train the adults on things a lot, not just how to work with young people, but one of the things we've been struggling with is the current kind of standard practice for our texting crew on the adult 988 line is one text at a time. These guys do 4 or 5 chats at a time, right? If things are crazy, and they do it really well. So there are skills to be shared for us to glean, and frankly, a lot of it is about understanding how your horizons can be bigger than you thought they could be, because they're not hemmed in by years of expectations that aren't necessarily still, reasonable.
Ebony, did you have a question? think you're on mute.
Okay, can y'all hear me now? Yes, I have a question.
There you go.
Two questions. One is, you know, with what's upon us in terms of the federal climate and, you know, what we're anticipating in terms of reduced funding for Medicaid, which means, you know, assumptions around, you know, loss of capacity. From the peer perspective, you know, what are things that we need to be thinking about and keeping in the forefront, especially as we are thinking about prioritizing and sustaining the workforce, but knowing that there's going to be a reduction. And, you know, I don't know if it was Kimberly or Janie that brought forward that we need to be super careful that we then don't start offloading other duties and clinical duties onto peers. But just any recommendations and things that, you know, y'all want to bring forward there. And then my other question was also, you know, I know that there's a lot of increasing safety issues that are impacting everyone regardless of what your role and scope is. And so any kind of considerations or thoughts that y'all want to bring forward there as well.
Janie, did you want to comment on that?
Sure. Thanks, Ebony, for the questions. I think if I understood I'll start with the second one real quick, just to comment on what we've done in regards to like outreach work or community based, primarily like out into you know, camps of folks living outside and things. It's team based. And I really try not to launch any programs where there's just a single FTE without some sort of additional support or champion point person at the location, such as an emergency department. And then just being at the OCBH conference last week, where I got to see several of you. The workshop I was in, you know, in relation to commercial payers, the ones that do, which surprised me, pay for peer support, which I was sad to find out kind of at the end is the same model and copied after the Medicaid model. And I wondered if there is a way to accreditate without clinifying peer services by us having to fit into a COA model or certification. But there is a national accreditation for peer programs. And so could Oregon and commercial payers explore that so that we on our own can have our own type?
Tammy, did you have a response to Ebony's question?
Yeah, just I guess as quickly and as not quickly, I think duplication. So how do we, when I was hearing the question about like with reduced funding and increased needs, what are some suggestions? And I would say how that we could have a critical eye on duplication. And I say that in part because I was invited into a conversation earlier this week where a program delivered this wonderful vision that they had for a workforce, and it was almost an exact mirror of the peer workforce. And so I think there's an example of potential duplication if we're not really collaborating with one another.
Clarissa, did you have a question?
Yes, thank you. This is for the team over at Youthline. I am just so impressed with you. I'm a psychiatric mental health nurse practitioner in Medford, Oregon, who's working with adolescents, and I'm wondering why I've never heard about you, why I'm the one going in and doing suicide trainings into our schools, that our middle schools and our high schools. You guys have an amazing program. It looks like you're in Portland. Why haven't I heard of you? Great job. So impressed.
Well, we are really psyched to connect with you, Clarissa. We have good friends and partners in Jackson County and in the Rogue Valley more broadly. Sean Martinez at Jackson County, and I don't know if you've ever bumped it. I'd love to connect you with Bob Wise at KOBI TV. You may have noticed that they've got a In This Together campaign. Actually, it's become now Tomorrow Needs You. It's kind of morphed from In This Together to Tomorrow Needs You, which, by the way, they stole from us, which we approve of. It's on Bob saw it on sweatshirts at Youthline. So we have a strong collaboration with folks in your way. So we just need to get into your direct space, which I will get follow-up information for you. And
That would be great because I work at a FQHC who has
Yeah.
extensive school programs also. So like why aren't
Fantastic.
we sending people your way? Great work though. Amazing. And thank you.
Yeah.
So the other thing that I would love to add to that is that we just, we've been working on this for a while. We realize that it's really hard to get to certain parts of the state and have added 2 positions to the Youthline team, one in Southern Oregon that will be like a community prevention wellness specialist to help support the coalitions, the schools, and the work that you do in such a way where really their whole job is there to help elevate what already exists and potentially weave Youthline, the work that we do on Youthline into the community as well, bringing
We
it all
would
together.
love that. And I would
Yeah, I
love to
think
talk more with you guys.
Yeah.
Yeah, well, I'll
Super
make sure,
excited.
we connect, Claire. So one other thing just to know about that we have a mini grant program for schools across Oregon that they can apply for $1,200, $1,500, $2,500 to do suicide prevention work of their own design at schools. And it's run the gamut from, on an institutional level, sometimes a school will apply for overtime so that they can get their teachers trained with assist or some other training. But also, kids at Redmond High felt that food anxiety was driving anxiety and depression there. So they wanted to start a food bank. So they got a grant to do that. It's a whole variety of things. We do it pretty much annually. OHA gave us money to do it one year. It worked so well that we started raising money to do it in subsequent years.
Well, just to add just a quick moment, we don't have beds for critically suicidal or mentally ill children down here, children and adolescents. We have 0 beds. I worked in the ICU and I remember hearing about a kid who was in peds for 8 or 9 months because he was so ill he couldn't go home and there were no beds. So we need programs like this so much here in Southern Oregon. I understand they exist up north, but like I always joke, there's nothing south of Roseburg. We need you guys. So thank you.
Yeah, we're excited to do it. We serve kids from Jackson County and Rogue Valley every day, and we're happy to connect with you.
Rachel, you had a question.
Yeah,
You've been waiting
thank you.
patiently.
No, I appreciate the discussion. And Clarissa, you can be my date for Lines for Life Gala next year because the teens just blow your mind, and maybe everyone on this call can be there next year.
I'm coming.
Okay, so I was glad, Jamie, that you brought up the clinicalizing of stuff. And while Karen left, or Kimberly, sorry, Janie's still here, and maybe others can speak to this. But so I know all of us on this council have our strengths, and then the thing that maybe we don't have our hands wrapped around, our arms wrapped around. Well, for me, it's been the peer support and trying to understand it. And so when I was first honored to be on this council, I reached out in that regulatory space to understand it from the space that I sit in now. So reached out to MACBO to understand, reached out to OHA to understand. And so I just have a couple of questions and then maybe not think through, we don't have time for that, but put a finer point on what potential policy things could be. So the clinicalization thing came up. I didn't have a word for it, but when I was speaking to OHA in the regulatory space in MACBO, we're always talking about stepping stone and entry points to workforce when we talk about workforce and how can we support people to grow. And then both spaces today, what was said, and then when I was speaking to OHA, is not everybody wants that. And so I have heard it now twice and really respect it and understand that now. But then it was mentioned, but some do. So I think it's not any policy solution to make sure it can happen or not happen, but it's much more around the conversations, how to support people. And so that kind of gets to my question and comment of when I got to the regulatory space, I thought, how is nurse wellness contribute to public protection? Because it does. In this regulatory space, when we get people to do investigations, it is often because of their wellness, whether it's substance abuse or mental health. So I have a real question around what are we doing for peers to make sure they're successful, whether it's, moving up the ladder, staying in the ladder, because I don't fully understand the regulatory space. And then a comment was made about the credentialing, the solution of credentialing for that space. And maybe that's it. And so, Janie, I think you mentioned that other states might be doing it, or maybe Tammy did, but is that what Oregon is lacking? Some kind of credentialing. So there is more of this professionalizing, but not clinicalizing. And then a safety net for making sure there's wellness. We're supporting people who are bringing their lived experience, and then potentially that regulatory space that supports it as well. So I just feel like there's something there that maybe this council, with all of the brains, can speak to, given all of that, and include the duplication that was mentioned, because that's getting brought up a lot in our subcommittee, on every time a peer does another peer type, they're having to do the whole thing over again of 40 hours, but there may only be 8 that are different. So I think the credentialing, hours, training / support. So it's a lot, but I do think there's probably something in what we've been talking about. And I don't know if um, anybody else has something to say to that.
Yeah, thanks. Thanks for that thought process. I was thinking, yes, 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 and all the things that have been shared, all the things the presenters have shared, and it does come back to that uniqueness. I mean, every profession has it. And what is that uniqueness of the peer support profession that really should be a fidelity model? There should be some teeth behind helping support staying within scope and keeping the peer workforce true to the core values, principles, scope of practice. And what I like to say here and in other places is we are the people we serve. We're just at a different place. And I can speak for myself, and I know I learned as I went along in my recovery what was possible, both mental health and addiction recovery. I'm not just talking about the substance use piece. The bar wasn't set low, and I was wanting to crash through it anyway. And I thought the clinical pathway was how I was going to progress. And I spent a year at Lewis and Clark, and while I appreciated what the next cohort of therapists from there was going to look like, I knew I was peer support through and through. But I also loved administration. And someone told me, because I didn't know it existed, there's a public administration degree. So I say that to say we've had peer support specialists who worked in the OHSU Impact program. He's a physician now. He was able to bust through some of those barriers that from his background that allowed him to get into med school. And we have IT specialists here and grow positions for folks who didn't think they'd be able to return to that sort of role because of their background. But as a peer org, we've been able to create things that aren't just a clinical pathway, but many people love being in that helping profession and do want to go the clinical pathway. So how do you support that and that development and that launching pad? Plus, for peer services, if we're doing our job right, there's a whole new group of folks who are ready to come and take our place as we move on to what's next. And so that's where I'll leave that.
Yeah, and I think the only last thing I'd say that I'm really deep into right now is this idea of predetermination and criminal background check. Because you spoke to me when you mentioned somebody that has been in prison for 10 years. And why should that person not also be a nurse or peer? And what are we doing in that space? And we're implementing across the state now kind of predetermination for people to check in with their regulatory space. Would I be able to get this if I invest in this education or whatnot? So I think if we can take some of these pieces of the credentialing, the criminal background check, the support, and then also that regulatory space, there's a model to potentially do something in policy to support it for reimbursement. And I'll stop there.
Thank you. Thank you, Rachel. Thank you for this great conversation. I would love to hear more. We could go on for a long time, but we are at time. So I just want to remind you that our next meeting is scheduled for November 6th from 2 to 4. If you haven't received a calendar invitation, please reach out to Chad and he will get you on the invite. At the next meeting, we're going to dive into the youth practice setting. So I hope to see you all then. Thank you all. Thank you to all the presenters. It's been a great, great meeting and presentation and discussion. Thank you. Have a good evening.